Someone you have to start?
Yes, I'm sharing the screen. How to reduce these echoes. Shall we switch off this microphone?
Yeah. Is it Yeah.
Okay, so shall we start? Still, I think there's still some echoes. Or okay. Yeah. I'm sorry, can you just how to mute the computer, because I think there's a lot of echoes.
Try now.
Okay. It's better right now. I think so. So can you check with who's logging through Teams just to confirm this voice is okay? Okay, so let's start on.
So, thank you.
Okay, thank you, Haitham. So what I'm going to talk today about how to approach a dizzy patient, and I'm trying to make it more simple as much as I can. But to be honest, approaching dizzy patient is something a bit complex because it's not just a single system that you are dealing with. As you see in this photo, we have different inputs starting from the balance system, the vestibular system. Okay, you're also depending on the proprioception, individual impulse, how you orient about the surrounding, and also about the auditory. So all of these inputs together going into some processing within cerebral cortex, within the brainstem, within the cerebellum, and all of this together have different reflex. If you remember, yes, the previous lecture that was given by David J. and other audiologist colleagues about we have main reflex, the vestibulo-ocular reflex and vestibulospinal reflex. And that's how we maintain the posture and we maintain the balance. Today, I'm not going to talk again in details about these reflex, but it's better just to check the previous lecture just to understand. But the idea of this photo is just to give you just imagination how it's not something simple, because we're dealing with different systems. That's why you really, even for us as a doctors, we start to feel dizzy when we are dealing with a patient who's presented with dizziness, because we don't know from where shall we start, from where is the point. But in these slides, if you see it, 70% of your diagnosis depending on your history taking skills. If you didn't take history taking properly, you never figure out what's the problem. And even the investigation, and this is maybe some people who will get surprised, it will only 10 to 20% of investigations. And also, as you say, the main actual benefit of the investigation is to guide your treatment, okay? But to reach the diagnosis, you have to assess the patient by yourself. You have to go through the history. You have to examine the patient properly and check what is the problem with this patient. And then after you reach at least 90% being sure about the diagnosis, you carry on with the investigation. So we carry some couple of questions about just small scenarios. So if you deal with this patient, I think it's maybe straightforward for many people. I'd like you guys, if you're able to interact or even write in the chat, it would be great. So do you get dizzy when you roll over the bed? So if you ask the patient about that, so the patient get dizzy when just rolling over the bed. So what it comes in your mind? Yeah, PPV. Yeah, this is something, just something simple. Yeah, and coming in our minds. Or do you feel fullness in your ears when you're dizzy?
This would be related to Meniere.
Could be related to Meniere. Could be related to something else as well. But yeah, Meniere. Are you light sensitive when you are dizzy? Receive a migraine? Yeah. Okay. So are you lightheaded when you get up for a bit for a second? Postural hypertension? Okay. The patient has severe vertigo more than 3 months, and since that he's dizzy most of the time, most of the day, and have also hypersensitivity to the motion, everything moving around. So, what do you think it might be?
It might be triple PD. I think it's like a sequelae of an acute vestibular neuritis, and then patient is losing his balance and not coping with normal movements. Is that it?
Yeah, totally agree with you. So we have a couple of common scenarios or common cases in business. I wish that when you're dealing with the patients, it'd be straightforward, like the question that I put it said, going to ask the patient just a simple, a single question, you get an answer, so you reach a diagnosis. But unfortunately, this is not the situation. We have a lot of things, and also this diagnosis. Sometimes you see a patient who have a PBV and Meniere disease, both of them. Some of them maybe have a vestibular migraine and PBV as well. So, and you may face a patient with vestibular neuritis, and after 3 weeks develop PBV, and later on develop still having PBV and have triple BND. So all this going together. And sometimes we have non-vestibular dizziness, which is completely related to other causes, different like neuropathy, like syncopal attack and postural hypertension, all these things. So I'm just trying to go ahead in a fast way with what is common to us as an ENT. Then we're going to show this approach, how you approach cases of a dizzy patient. So just give a small idea. I'm not going to talk in details about PPV, which is the commonest cause of episodic vertigo. We have two pathways, and is it an episodic vertigo or is it a continuous? The patient keep feeling dizzy most of the day. So if it just come in episodes, we're going to think about it, the PPV, especially for a positional nystagmus. But one of the important things that some of you guys may forget to document or may forget to look on it is it's not only that the patient has an nystagmus in position, you have to look into the direction and the character of these positions, because some of these position nystagmus may be indicator for a central disease. So it's not necessary if the patient has a positional vertigo that it's a PBV. It could be something else. It could be something serious. But what we have as a common is for the posterior canal PBV, and in the video, as you see, this Epley maneuver that was done by the doctors, and you will able to see the nystagmus. And the character of this nystagmus is positional, and it is rotatory. And as you see, geotropic, you can look at into the pupil and see how it is moving and how it is rolling again around it. So this is character of posterior canal nystagmus, and what we call mostly is about canalitholysis. So, and we have another types of PBV, which is a less common, it's only in 5%. And this is for the left semicircular canal, lateral semicircular canal, where we can do this roll test. So we see the patient at 30 degree, like in this video, and rotate the head in one direction. And you can see the nystagmus, how it is, and it's just a horizontal. So that's why you need to look at the direction. of the nystagmus, not only if the nystagmus is present or the patient is dizzy. You have, so if, for example, let's assume that you did a BBV for a patient and the patient is feeling dizzy, but he doesn't feel, you haven't been able to notice the nystagmus. I would actually ask for someone else to have a look. Maybe you're going to use a Frenzel. We need to ensure about the character of these nystagmus. And the most important, this is another photo of, just to show you the typical nystagmus of the BBV. And you can see in both these two videos how the pupil keeps rotating. And this is the typical. Why it's very important to know the typical, because you may see some atypical features of nystagmus that may be indicated for a central disease. And that's why we have some red flags, because positional vertigo could happen with MS, could happen with some CNS disorders, the cerebellum, could happen with vertebropatellar insufficiency. So all these patients will have a positional vertigo. So it's not what I need. The most important message here: it's not important if you have any history of positional vertigo. It means that this patient has BBV. Okay, so you need to request MRI brain, including posterior fossa and IAC, if you not any atypical nystagmus, okay, for BBV types, or in your further examination, because you need to do a full assessment, full examination. If you catch up any signs of central weakness or any cerebral functions, or when you did an IPLI for these patients, it's not improving. So this will be a flagger for you. There's something behind this problem. We need to go further, okay? And at that point, we need to arrange an MRI scan, which is very important. The second, which common things, is vestibular neuritis, but recently they changed the name into acute unilateral peripheral vestibulopathy, and is something more common and more general to include a lot of things. This would also include vestibulopathy, would include not necessary to be only vestibular neuritis. Okay, so just go ahead. There's a problem, or just the fire check. It's fine. So with this character, with the vestibular neuritis, definitely not miss it. It's a continuous vertigo with nausea and vomiting and gait instability. But clinical assessment is very important, and you may be, guys, you may be aware of the HANDS, which is head impulse, nystagmus, and test of skew. So when you deal with any patient you're suspecting vestibular neuritis, you have to assess the nystagmus, and spontaneous nystagmus is crucial for the sensitivity of HANDS. If you're not able to assess the nystagmus, HANDS is not sensitive to depend on it and ensure that it's not central. And I brought some photos for how to see the difference between. So if you see the first on the left, this is the nystagmus of the peripheral course, but in the middle you can see direction changing nystagmus, which is a characteristics for the central lesion. Okay, and the last thing, this is the test of skew that we are doing it. So if we get any any positive findings like normal head impulse test and direction changing nystagmus or positive skew, this patients will be a central cause, because the posterior stroke in the posterior circulation will be presented in the same way, so like the vestibular neuritis. This is just one of the commonest things. And one of the important messages I'd like to do, Meniere disease. Yeah.
So you mean when there is a positive hint, this is a central cause of vertigo, right?
Yes.
Okay. If it is a negative hint, so this is a peripheral type.
Yes. And negative hint means abnormal head, or the vestibular nystagmus. I mean, you see like torsional, horizontal nystagmus, and definitely no skew deviation. So it's a peripheral. If you are not sure, I would go for MRI.
So what do you mean by skew deviation?
Skew deviation, as you see in this photo, you're going to cover a single eye, then just move it away. If you can see, if you look into this photo, Okay, and look into the right eye. You see how it is it's moving superiorly to the to the middle. So this is just have a look into the eye and see. This is how it looks like in the skew deviation.
Okay.
Okay.
Thank you.
Next things, just the simple things. Meniere is a rare disease. It's not common as many people think about
Stella,
it.
can I just comment on the
Yes, yes.
impulse test and the hints test? So it's also sometimes you get a with the head impulse test. I think if you get a positive test in both directions, if they get corrective saccades in both directions, it's also suggestive of a central cause. So you can get normal head impulse test, but if you get corrective saccade on one side and then you do the other side, there's the corrective saccade to the other side, then it's also a sign of a central cause.
Yeah, that's great. Thank you, Amr, for this add for these points. Yes, because it's very important. And I'd like to add another things from what you said. If you get anything that it's not the standard, I mean, we shouldn't have abnormal head corrective saccadic movement in both direction, because this is definitely not a peripheral lesion. So if you see anything not typical, so think about the central cause. Okay, so if there's any questions for this point? Okay. The second thing, as I say, Meniere disease is a rare disease. It's not common things. Unfortunately, we get many referral from the GP about Meniere disease that they think it's something common, but it's not common. What is common, to be honest, is vestibular migraine, and it's also underdiagnosed. Many patients who have vestibular migraine, not all of them being managed as a migraine, getting out of beta histone medications or whatever, which are without actually getting much improvement. But we have some points in vestibular migraine will keep you thinking about it, especially with the long-lasting episodes of feeling dizzy, and this dizziness is actually aggravated or provoked by some factors like being in some photophobia, any visual light light stimulus or any sounds. Some of these patients may present with a visual aura and or headache, which would be typical. But also one of the tricks, you can ask the patients about the past medical history. Some of them may presented with recurrent actually attending to the emergency department when the patient was a child because of the abdominal pain, recurrent abdominal pain. So migraine, one of the factors that actually the recurrent abdominal pain and present to the AD, especially in the pediatric group, is a characteristic finding for vestibular migraine as well. And this is how you're going to catch up from the history. You may also ask it if she's a female about during the menstruation period, is this disease episodes getting worse? So all these are triggers for the migraine. So that's how you think. Vestibular migraine is more common than the Meniere. Sometimes we actually both of them gets in the same points, and you're treating the vestibular migraine as you're treating Meniere. Okay, for the Meniere, I think most of you guys are aware about it's episodic vertigo with unilateral tinnitus or hearing loss without having specific triggers. It's different, and that's why it's different from the vestibular migraine. The last thing I would like to talk about is the triple BD, and the 6 symptoms. When you think about triple BD, when the patients talk to you about feeling dizzy for a long time, some of them say about a couple of months, okay, and its characteristics just dizziness. It's not a vertigo, it's not a spinning vertigo, and they are feeling most of the time tired, feeling lightheadedness, feeling that they couldn't stand on their feet, they couldn't actually deal with any visual stimulus. They are feeling so tired, and even when they are going into any areas of crowd, maybe in the past, maybe in anywhere, it's this dizziness getting worse. So it's continuous most of the time, and they are feeling, most of them, they are unsteady, they are unstable. Most probably, guys, you've been seeing this patient. Triple B and D is common, and we are seeing many patients having these issues, and it's actually having some psychological inputs as well with the because of that. The management of these patients is a bit more for vestibular rehab and all these things, but it's very important to know what's it. So you're not going to prescribe sinerzine, beta-histine, or prochloromazine or anything, because you don't know what you are dealing with it, and you just give the patients any medication. So this is a Parani diagnostic criteria. So they put it for persistent postural dizziness, and it's one of the important slides. And they put actual characters, and it's very important to put in your minds that you get one of these symptoms at least for more than 3 months. Usually these symptoms preceded by having vestibular neuritis or anything like that, and these symptoms be there all the day without specific provocation or anything that disturb or causing this problem. So let's talk about the approach right now. I just try to give a short history how to deal it. So let's assume that Ahmed, you're taking history, or Haytham, you're taking history from a dizzy patient. So the first and the most important thing, you're going to ask the patient, please describe to me in your own word, how do you feel? And just listen. 50% of your history scan is just to listen to the patient. And while you are listening, you're going to analyze what the patient said. So, and from that point, you're able to cover these points: the onset, when did it start, the course, is it getting worse or not, is it continuous, is it episodic? Okay, and even for these episodes, and even for these episodes, what's the triggers of it and what relieve it as well. So if this episode's getting worse within time, is it relief or not? And we also look for the previous complaint. If the patient was feeling dizzy in the past, how it gets relieved or not. Then you're going through the differential diagnosis. We have autological causes. Okay, ask about ear discharge, tinnitus, hearing loss, illness, or the other symptoms. About the migraine, ask about headache, sensitivity to light or sounds. Neurological causes, about having a weakness, any numbness in the feet, in previous TIA, stroke. And cardiac, if the patient has any syncopal attack, lost of consciousness, or in the past. And the most important, one of the important thing is the past history. And we're about the past history, about the ear surgery, or any previous head trauma or head injury, and the medical history, specifically about the hypertension and diabetes. So for the medication history, it's very special if this patient been on blood pressure medication, or had any previous history of using vestibulotoxic medication. And the last thing is for the social history, if there's any stressful condition right now, recently that is doing it. So I just made this, try to make it simple for how to approach dizzy patients. And I actually adapted from one of the lectures from Professor Ray about how to differentiate between Meniere's disease and vestibular migraine. So I adapted this mnemonic of using 12B from him. But generally speaking, we're talking about episodic and continuous dizziness. So for continuous dizziness, this is mainly, we have 3 conditions that presented the continuous dizziness: either vestibular neuritis, either central disease, or triple BND. So any of these disorders were presented with a continuous dizziness. So for vestibular neuritis, usually it's acute onset without having any neurological symptoms. If the patient has any positive neurological symptoms, and for example, he's just lying in the bed, couldn't stand, so it's a central disease. And the last thing is, for triple BND, it's non-spinning vertigo for more than 3 months without any specific triggers, and there is some previous history of vestibular problem with psychological stress. So for episodic, we have 12B. And for 12B, if you put it in your minds as a trigger for the episodic, you nearly been able to identify where is the problem. Okay, so as you see, there is a lot of cause, and usually you will face these patients who are having all of these problems, and that's why dizzy patients is a bit tricky when you deal with it. So the first thing you ask about, is it getting worse with any positions, and you're rolling with anything, and you're thinking about the PPV. Okay, but you also don't forget to ask about any worsening with postural, any photophobia or phonophobia, which is a trigger for vestibular migraine. Okay, ask a patient any change in pressure, like any sudden noise, sudden sounds that may cause this worsening of this dizziness. Periods, yeah, I talked about the menstruation, poor hearing, about the Meniere disease, and psychological, if there is any anxiety, hyperventilation. And the next one is about the palpitation of the syncope, if there's a cardiac cause or panic attack. Okay, and ask about the bills. Okay, I mean the medication. If the patient's been on any medication for like a diuretics or any hypertension medications, if he changed his medication recently before developing this dizziness, other things like pitimal, paresthesia, paroxysmia. So all of these are when you're dealing with episodic vertigo. As you say, there is a wide differential diagnosis that you need to think about it, and you need to consider it while you're changing. Okay, so then the next thing is for the examination. So we have actually two columns. So the first thing is for nystagmus and head impulse test. This is mainly for the vestibulo-ocular reflex. So when you look into the patients and a sudden nystagmus, you're starting with a spontaneous nystagmus, then smooth pursued nystagmus. I'm just checking something with the camera. Yeah. So you look into the spontaneous nystagmus. Sorry, can we just, after we finish, just so I have 10 minutes to finish, sorry. If
yeah.
not something urgent, because of this interruption, please.
You have to stop.
We just, after we finish, just please, just give me, yeah, I'm just recording in the video. So for the nystagmus, when we talk about the spontaneous nystagmus, okay, we have to look directly into how it looks like. If there is a horizontal nystagmus, I mean, this is a characteristic for peripheral nystagmus. If it's never changing the directions, always in the same side, on the right side, or always on the left side. And the most important trick as well is it's suppressed on fixation. So you have just look into the pupil and see how it looks like. Then, but for the central nystagmus, as I showed you before in the slides, it's keep changing the direction. So whatever you're doing in the right or left keeps changing, and it's without showing any suppression. Then you're going to do the smooth pursuit. Smooth pursuit, you just moving your fingers and ask the patients to follow your fingers while you're moving slowly, and see if it's just following, if the pupil is following smoothly, it's a peripheral. If it keeps like corrective cascade, saccadic movement or overshooting, this is a character for central. Saccadic, you're going to ask the patients, for example, like look into my nose and my finger. So you say finger, nose, finger, or look into two fingers, say right, left, right, left. So you're going to watch how he's moving his pupil, if it is it normal or is it just overshooting. Then you're going to do the gaze evoked, okay? And when you do the gaze evoked, just which that you're doing within 30 degree, not more than that, okay? So you're able to see how is actually the fast phase and slow phases is changing. Skew deviation, I showed you earlier. For the head impulse test, you're going to do it to see if it's a peripheral or central. And usually for the peripheral, there's a catch-up saccadic movement. Position nystagmus, and we will talk about position nystagmus again. We need to comment on the characters, the character of the nystagmus. So when the Dix-Hallpike test, usually the nystagmus is torsional, geotropic, with some latency, and the transient disappear. But for the central, it's atypical. Some of them will be vertical, some of them will be persistent, never reduce, and all these things. Then you're going to do supine head roll. And supine head roll in 30 degree, you're going to just roll the the patient head to the right and left and look into the pupil, see how it's moving. It's just transient. Is it geotropic or agiotropic? Whatever. Both of them is actually diagnostic for PPV. This only make a difference if it is the problem is the crystals in the copula or is it the canal. But it's been the same, I mean, in the diagnosis of PPV. But if it's persistent nystagmus, there's a characteristic for central. Then we're going to the vestibulospinal reflex, and we have two tests. One of them, Romberg test. And for the Romberg test, all of you guys know it actually. We just ask the patient to stand, put his hand on the sides. So just do normal Romberg and say if it's excessive sway. It could be peripheral or central. But if the patient's unable to stand from the start, definitely it's a central. Unterberger test, it's not a diagnostic alone, but it will give us an idea about when we are thinking about, okay, this could be a vestibular cause and could be a peripheral cause. So let's see where is the problem actually. So it's an additive test, but it's not only diagnostic by its own. So we ask the patient to extend their arms in front of them and close their eye and just step on place and how much they're going to deviate. So usually for this, the patient starting to deviate more around 30 degrees more toward where is the site of labyrinthine paresis. And the last thing is a cerebellar function test and going to assess if there is any dysmetria, if there is any tremors. And this is definitely will be concerning for central lesion. So I'm just trying to just give an idea how to approach it in terms of history and in terms of history and examination. And I'm happy if anyone has questions that we can go through it. And so if anyone has questions for. Okay.
Thank you.
Okay, so thank you guys. And in case of any further question later on, if regarding this topic, just let me know and we can cover it later as well. Thank you for attendance. Okay, thank you.
Thank you so much.